Welcome back to the podcast, Can Silicon Valley Solve Healthcare? The podcast where healthcare leaders talk about technology, technology leaders talk about healthcare, investors talk about impact, patients have a voice, and everyone has an opinion. Hi, welcome to another episode of Can Silicon Valley Solve Healthcare? I'm your host, Adam Silverman, Chief Medical Officer at Syllable. Today, I am absolutely privileged to have a physician joining us on the podcast today. Steve, welcome to the podcast.
Adam, it's great to be here today. Thank you so much for having me. Looking forward to the conversation.
Absolutely. I've been looking forward to this since we first hatched the idea of having you on the podcast. Why don't you tell the audience a little bit about yourself and a little bit about your background?
Yeah, so I'm a kid from the Bronx, Adam. I'm born and raised not too far from Yankee Stadium. I'm a Mets fan now. I went to school, local schools in the Bronx, and then attended a small liberal arts college in upstate New York. And then to the sheer surprise of my family, I actually got into medical school. I didn't think I had a chance, but I ended up going to UVA, Oahu. And, I'm a Oahu.
Excellent.
Had a great experience in medical school. Actually, then went and did an internship, went into the military as a primary care doc for several years. I ran a medical clinic as a junior officer, and then had a pivot. I wanted to be a cardiovascular surgeon, went to University of Rochester to start my surgical training as a CV surgeon, and then had another pivot. I just didn't like people dying on me. I just realized I'd like to work with my hands, so I pivoted again, and I came out here to UConn to do an orthopedic residency here in the University of Connecticut, and then again, probably a little bit of luck, I got into a fellowship at Mass General. I spent a year teaching at Harvard and doing my fellowship in arthroplasty, and then came back here in the late 80s to private practice of orthopedics, and that's where I've been ever since.
Excellent. Now, in addition to being an orthopedic surgeon, you have always, at least for the time that I've known, you always had sort of an entrepreneurial bent. You mentioned going out into private practice, and for people that don't follow healthcare or participate in healthcare as closely as you and I have, can you sort of let the audience in a little bit on the difference between private practice and employed or academic?
Yeah, that's a great lead question, Adam. And it's funny. I do give talks from time to time. I was just at a great conference called the PHA, Physician-Led Healthcare for America, largely driven by private practice entrepreneurs who want to take back healthcare. And when I give a talk, I have my title slide, my disclosure slide, and the third slide is my bias. And I think it's more important than disclosure to be transparent with your biases. And I really do believe in maintaining the sanctity and the autonomy of the private practice of medicine, not necessarily the way we've been doing it, but as entrepreneurs and as enablers of the value healthcare transformation. And I think we can do that in the private sector, being self-employed, than when you're employed by Optum or by any of the major health systems. And as you know, 74% of our colleagues today, Adam, are employed. That may have hit a peak, and we may be seeing a little bit of a turnaround on that.
Now, in addition to having your own private practice in orthopedic surgery and arthroplasty, you were very much involved in the development of an organization called the Connecticut Joint Replacement Institute. Can you describe that a little bit for our audience?
Yeah, boy, that's our baby, and I'm just so happy. You asked a question before, that I'm an entrepreneur and innovator. I think about innovation in two ways. I've read about it. We're social innovators and we're technical innovators, and we're probably more adept at social innovation because when we were hunter-gatherers in small tribes, we all had to continue how to make this community better. But the CJRI is a brainchild of 10 private practice orthopedic surgeons who back in 2006 put our differences apart. We came from 5 different practices, Adam, and as you know, we were fiercely competitive in which hospital we were part of. But we were getting 3 cases done in a day. We had no input whatsoever on any of the operations. We saw this impending epidemic, if you would, of folks in my demographic reaching age and coming through with this vast number of arthroplasty, joint replacements. And we came up with a novel idea. And We pitched it to one hospital. They turned us down. We said, "Are you sure?" They said, "We're sure." We pitched it to another hospital where you and I worked together at St. Francis, and they said, "Come on over." And it was really fascinating because the docs, although we did have our ridiculous competitive differences, it was really social innovation because we came together and said this: let's build a world-class destination site for total joint replacement. That's it. And that was a guiding light. That was our vision. We codified that into an LLC. We organized a company, and that company entered into the contractual arrangement with St. Francis. And within the limits of the law, Adam, for those great 12, 13 years, we kind of took over and ran it, and we needed something, we got it. And it was really, I don't know if you ever read the book, Finding Allies and Building Alliances.
Mm-hmm.
Did you ever read that book, Adam?
Yes.
By Governor Levitt. It explained to me why CJRI worked so well. Even though we didn't necessarily love each other, we didn't all go out together for dinner, we had common enemies, right? We had the insurance companies,
Yep.
and the hospitals weren't our friends.
Absolutely.
And that brought us together into a value alliance that became sort of unstoppable for many, many years.
And it was pretty good, wasn't it? The quality coming from CJRI. It was what
It was one of the best in the country, Adam, and we're just very lucky that everyone shared this passion. And keep in mind now, you know a little bit about orthopedic surgeons. We're not short on ego. And forget 10 orthopedic surgeons to agree to standardizing their care plan and making data-driven decisions in 2006 was unheard of. Everybody did whatever the hell you wanted, but we wanted to be able to measure our outcomes in 2006. One of our core principles to the CEO at St. Francis, we wanted a registry, every patient in the registry, and 4 FTEs. We didn't know if we needed 3 or 4. We picked the number 4. So every patient, now 50,000 patients strong, Adam, are in our registry. We study that. We look at our outcomes. We do make data-driven decisions, and we get better and better and better. So, I will tell you that the talk I just gave at this PHA meeting was about CJRI, and we call it a validated COE. Because, if you drive, you're up in Maine, we're in Connecticut, you see all these billboards about we're centers of this and centers of that. But our database, our registry, has been credentialed by the Validation Institute, who you probably know about, and by the American Board of Orthopedic Surgeons. And there are only 5 registries in the country that are credentialed by the ABOS. What do we get for that? Our data is part of the leverage for our physicians participating in outcomes research. They get some credits towards their board renewal. So, yeah, we're very, very proud of CJRI, and no one thought we could ever pull it off. And we had such explosive velocity, almost like a digital startup,
Right.
that we were unstoppable for years.
So, I mean, let's call it for what it was. It was a top 5 joint replacement center of excellence in the country. In Hartford, Connecticut, of all places, not affiliated with any significant brand name organization. This wasn't Mass General. This wasn't the Cleveland Clinic. This wasn't Stanford Healthcare. This was Hartford, Connecticut. So how does that happen? How what is the special sauce here?
Well, that comes back to the shared vision. Whenever our mission statement ended with the patient and their family are always at the top of the pyramid. Period. So anytime we get into a squabble about resources and finances and models, we say, what is better for the patient and the family? And, the secret sauce was a business model that worked, relationship with our hospital partner that worked, built on trust. It's all built on trust, as you well know. We had a registry for all of our data. We were ISO 9001 credentials. We had a quality management system. We got involved in alternative payment models. In 2009, we had a bundle. We did TDABC, time-driven activity-based costing, so that we knew the cost of every paperclip, let alone implant. And
that
we
was
had
Professor Porter, wasn't it?
That's right, exactly. That's Kaplan, to be fair.
That's Kaplan, right.
Kaplan. Kaplan is the accountant part of the equation. But, Chris and Amit, as you know who they are, gave us that responsibility of running this as a tight ship. And we did. We had the fiduciary responsibility to the bottom line. We had the patients were happy as our customer, the surgeons were happy, the payer community was happy, and it was really sort of a remarkable experience. And we'll talk about this more and more. That this transformation, the title is about Silicon Valley, but for folks like us, Adam, and physicians, we have to lead it, and it's about behavioral change. It's about the bigger picture. It's not about me as a specialist and you as a primary care doc, right? It's taken on a different, more grand meaning. And it is about collaboration and behavioral change. And if we could do that with 10 orthopedic surgeons, then we can do it anywhere in the world. But to address your point, it was an interesting point you raised about brand. So I was invited to speak all over the country, people I knew that I was connected with, because a lot of this COE work was arthroplasty because we were a focused factory, right? We were a factory. We just wanted healthy patients with great outcomes. And so I was invited to speak with Mayo and Cleveland Clinic and Hopkins and so on and so forth. And the reason why they invited me, representing CJRI, is because we represented just common folk, right? We were a community-based, just as what you were saying, right? Because what happens is that the 200 orthopedic surgeons that attend these meetings go, oh, well, you're Hopkins and you're Mayo.
Right.
We're just CJRI. We're just five Joes from Hartford, right? We're not academics necessarily. Some of us do a little bit of publishing, but that's why our message resonated throughout the country, is because we were just regular folks who banded together to see a better way for patient care and patient delivery.
So in your introduction, you mentioned the military, you mentioned primary care, you mentioned maybe being a cardiovascular surgeon. You talked about your medical training. You didn't talk about getting an MBA. You didn't talk about getting, advanced training in entrepreneurship. Was this just part of what you thought being a doctor should be like, or how does this develop in you?
It's crazy. When I think of that question at this time of my life, I think about that how my life has been a series of fortuitous, seemingly unrelated but mysteriously connected events that kind of unfold. And I can't tell you, none of it was planned, of course. And to be perfectly transparent to you and your listeners, I'm an MBA dropout. I started, I don't know, 8 years ago. I was irrationally exuberant. RPI had an EMBA program here. And I sat through 6 weeks of this, and they would have me read 2 books in a week and write a report while having a full practice, while running CJRI. And I really had to do something. I was terribly embarrassed and I had to withdraw. Some of the 6 best weeks of my life, but it was not online. It was in class, and it was going out of my mind. So I backed out. But you know what? I actually I love learning, but I probably didn't need it to make me a better leader or so forth. But it was fabulous. So just a bunch of unrelated events, Adam. I've always been inquisitive about trying to improve whatever I'm involved in. And it just it kind of zigged and zagged. I realized I didn't like CV. I didn't like doing amputations. I'm a natural tinker. I think orthopedic surgeons are wired a little weird. Maybe our preloaded DNA. We're fixers. We like to tinker with stuff, play with tools. And we also, in case you haven't noticed, have a very short attention span. So as a primary care doc, I put some medication, and like 6 weeks later, I check the blood pressure. I mean, I do my surgeries, and in the recovery room, I know if I did a good job or I did. It's like immediate gratification. So we all kind of migrate. If you listen to your spirits, you kind of know what you want to do.
So I want to shift the discussion a little bit. One of the words that you used when you described CJRI was a bundle. So a bundle being a bundle of services for a specific price, and it's a concept that came up as part of the movement to value, and you're a part of that movement to value and value-based care. So I want to get into this concept of value-based care, and what I want to sort of drill down into is, in my mind, what you described as being an orthopedic surgeon, which is we want to be the most efficient in terms of arthroplasty, let's say, you want to be the most efficient provider of high quality arthroplasty services. Bring somebody in, put a new knee in, send them on their way, and keep them healthy. And I'd say historically, probably orthopedic surgeons were pretty good fee for service physicians. They knew exactly what they were going to get paid for each one, and they knew what their overhead was, and that was a pretty good gravy train. But then you start talking about CJRI and putting the patient and the family at the top, and then you make mention of this thing called a bundle. So, what got you into thinking about not just putting the 10 best, not just having good outcomes, but being willing to put you and your colleagues' reputation and to some degree financial remuneration on the line by embracing these concepts of value-based healthcare?
So there's a two-legged answer to that, Adam. At the micro level, and there's one at the macro level. At the micro level, for orthopedic surgeons, the better we got, the more efficient we got, the more our rates got cut. So, you think about it, when I went into practice in the late 80s, patients came in 2 days before surgery into the hospital. They stayed for 7 days, and they all went to an extended care. Think about it. Now,
Wow.
85% are same day or overnight stay. I ask you, first of all, who created that value? We did. Those are our protocols, right? We got them out of the hospital. We brought them in later. We created all of that value. And I ask you, where did that value go? We got our fees cut, right? So yes, we went from 3 cases a day up to as many as 8 cases a day at CJRI. Efficiencies were like being in a ballet. Put out your hand, you get an instrument, you're done, and incredibly coordinated experience. Patients love it. And the credit we got for that is we got our fees cut. So I get paid now less than half, unadjusted for inflation, of what we got paid in the late 80s. It's not in any way complaining. But what I'm pointing out here is that the better we got, the more we got cut. We gave away that value. So the macro answer to your question is I started seeing the handwriting on the wall. And by all means, I'm not the brightest guy in the room, but I do have ability to see things coming down in the future. I saw where fee-for-service was going, and I saw an opportunity. So what a bundle means is, and you touched on the definition, but it's a very well-defined package of goods and services that are delivered by multiple providers over a defined period of time, accepting accountability with a warranty and a positive margin. So for us, it brought in the hospital as a partner and anesthesia because we deliver those services. And it took us 13 months out and about $70,000 of collective legal fees because marrying two for-profit companies and the nonprofit hospital, no one makes that easy, as you know. So we had an army of healthcare attorneys, and it's cool. So we actually became, Adam, a CIN. Our bundle, which we call the Basket of Care Agreement, is actually a CIN. We share data, we share protocols.
Clinically Integrated Network, CIN.
Yes, clinically integrated. We shared protocols, we shared risk, and we shared revenue. So how do you share risk, and in particular, how do you share revenue? Well, you can't just, you ask 10 orthopedic surgeons in the room what they're worth, you'd be surprised to hear those answers. But when you subject it to TDABC, I'll repeat, time-driven activity-based costing, or what is the true cost of delivering your service over a 90-day episode? Guess what? The surgeons went from 10% of the dollar to 17% of the dollar, and anesthesia went from 5% of the dollar to 7%. So we got a 70% raise, and they got a 40% raise, and the hospital took a 9% haircut. That's just the way the numbers worked out. We didn't rig them. They were validated by all attorneys. But that we realized right then that fee-for-service was not even justified based on the value we were creating, putting forth for our patients. So it was funny because then my colleagues, well, it's a race to the bottom. Come on, guys, look at fee-for-service, right? Now, super macro level, you and I have had these conversations. Fee-for-service is the root evil cause of the mess we're in now. Period.
Right.
It doesn't foster creativity. It just fosters a little better efficiency so you can make more money, but doesn't solve complex healthcare problems. And it's toxic and it becomes overwhelming. And whether you're remunerated by dollars or by RVUs, it is the root cause of our problems today.
You've sold me on this movement to value with CJRI. You've now moved further onto value with a new endeavor that's called Upswing Health. Tell us about Upswing Health.
It's very interesting. So I think, as I mentioned, I think of innovation in terms of social and technical. And thinking about this conversation we're going to have today, I've been a little lucky on both sides because early on in my career, Adam, I was a developer. I actually have a patent on an implant system. It's been sold now, but it was a unique implant system for its time for a revision component. So I've had some technical innovation. I work with the device industry on the social innovation skills, and some of it may be inherent, but you got to work at it too. But you think about CJRI, really was behavioral transformation. And so was the Moving to Value Alliance. We're an eclectic group of physicians and brokers and consultants and hospital administrators. So that's really a social innovation in itself. But here's the thing about CJRI. So we think we've had an impact on brick and mortar orthopedics. The model, as you know, for arthroplasty was so successful that my colleagues who hated us for a year or two said, "We don't hate you that much. This sounds like a good idea. Could you, you know who I'm talking about, could you give us your operating agreement and your consulting agreement?" It was like thousands of dollars of legal fees. So, sure, here, take it. And they built the Connecticut Spine Institute with the same DNA, the same value proposition, same connections to the Harvard Business School. And then we did that for sports, and we did it for trauma. And as you know, for 16 years, I had the honor of overseeing all four of those institutes as a physician executive. But it's all been tied to value. But the thing about it is we've made a dent in brick and mortar, but 90% of orthopedics is practiced in the office, in the ED or emergency rooms, in urgent care centers, not in the operating room, thank God. So my partner and I, Dr. Jay Kilm, we go back now 6 years. The model has pivoted, but we said, we've got some good ideas in brick and mortar. Let's try to find a better way in non-operative orthopedics, and let's build an MSK system the way it should be practiced, not the way it is now. So, for example, what I mean by that, Adam, if I may, is that when somebody has an injury, we call it the ouch moment. You have an ouch moment. We all have them. 1 in 3 Americans every year. If it's a bad ouch, you go, and you don't have a friend named Adam Silverman or Steve Schutzer, if it's a bad ouch, you're going to run to the ED. And here in the state of Connecticut, the state pays $2 million a year on ankle sprains. Simple ankle sprain, which you just need a couple of exercises for. And if it's
for state employees, you mean? When you say the state of Connecticut, you mean state employees?
State employees, yeah. It's one of our clients is state employees, and we just looked at their database. But that's what people do and have a bad out. Folks want answers to 2 questions, Adam. What do I have and where do I go? That's all. That's what they want to know, all right? And if you've got a friend that's an orthopedic surgeon, a friend that's a physician, I probably get 2 or 3 calls a week or emails. What do I need to do? Put some ice on and be fine. And right. But if you don't, sometimes you go to your primary care doc, and we've talked a little bit about fee-for-service. And look, our brothers and sisters in primary care, when they, in fee-for-service, they got 15, 18 minutes to see a comorbid diabetic, who, by the way, says my shoulder hurts. They're going to get an MRI scan. They're going to get sent to physical therapy or sent to a surgeon. And it's just wrong. It's dysfunctional. It's not aligned. It's not coordinated. So Jay and I had this idea to build this company called Upswing Health, and it's a virtual front door model. In fact, it's all virtual, but it's the virtual front door to MSK care. And if you know, MSK is one of the top 3 categories of spend by the payers, by the employers, by the government. So it's virtual first, and we build it in a very systematic way that I can tell you a little bit more about if you'd like.
Yeah, please do.
So if you have an injury, Adam, or anybody, your listeners, they can go to upswinghealth.com. It's free. And ironically, and as an entrepreneur, Adam, you would We've had 1.47 million people since the pandemic come to our site, use our technology, and we never monetize that. It's sort of a giveaway. 2,000 to 2,500 people a day. And what they do is they come to our site, and again, any of your listeners can do that, upswinghealth.com, click on individual. And then, so Jay and I and our really smart group of healthcare advisors have built, it's AI driven, it's not GPT-4, but it's algorithmically driven interaction with you as a patient, very much with the same type of scenario that you would be in my office. I would say, Adam, where does it hurt? And you point to it on our homogram, and then we would ask a series of questions. Does it radiate? Does it click? Does it? All the questions we ask, as if it duplicates the relationship. And it comes out with a differential. And the differential has been validated. It's about 75% accurate based on office testing. But it gives you differential, and you click on another button, you get to really good PDFs that are written at an 8th grade level, not to be pedantic, but to give people usable information. Like, you're not going to die of bone cancer because you have shoulder pain, which if you look at some of the others that, you read this, oh my God, I've got to have cancer.
Right.
But so you go through that, and then you click another button, it'll give you exercises, PDFs that are married to that condition. And a lot of people, that's all they want. When do I need to see a doctor? When do I need to go to the ED? And all that guidance. And many times people just want some simple advice, right? But if not, and they want to talk to a human being, and I do think even with GPT-4, people are going to want to talk like we are, face-to-face with a human, not a bot. And we have our front line of providers are certified athletic trainers. So Jay and I thought for a long time, and we know the cost of every caregiver in orthopedics doing a TDABC analysis. You don't need a gray-haired senior orthopedic surgeon for every person with shoulder or back pain. You just don't. So we worked our way down the ecosystem, and Jay, being a sports medicine surgeon, has worked with ATCs for 35 years. They're probably the most undervalued stakeholder in MSK. They have masters in motion and kinesiology. The ones we have 10 years of experience. They tend to injured athletes. They're liaisons, and they're really good at general advice. And that's what they do. They'll go over your responses to your symptom checker, go over your differential. Now we have pose recognition technology on your iPhone, so they can actually measure your motion in different planes. And then with all of that information, Adam, they tailor a rehabilitation program. And do this. Let's try this, Dr. Sullivan, for a few days. This is the program, and we have a video set of exercise. We happen to use MedBridge. And then the coaches do something that you and I have never been able to do. They actually check back in 4 or 5 days, set up another, most of it is by Zoom. And they go, Dr. Sullivan, how's your shoulder doing? Well, it's a little better, but let me see how you're doing those exercises. And they give them instant feedback. You're doing this and that and so forth. And let's test you again and see if your motion is getting better. So they engage the patient in their own care journey. But they're also smart. They know their limits. They're not PTs or not physicians. I'm the CMO of the company. And I every day I go into their notes, review them, make sure they're staying in the lane and so forth. But they know their limits. So if there are any red flags, like you or I or our kids are running on the field, your knee pops and fills with blood, you need to see a surgeon. Right. You don't need 6 months of physical therapy. You tore your ACL, right? Or if somebody's not getting better at them on a pathway that they expect, they'll escalate to the third box in our company. And we have employed a group called primary care sports medicine docs. These are orthopedic specialists just like me, but they don't operate. So consequently, they cost less, they're better at office orthopedics. And with that 3 stack, technology, our algorithms, our coaches that are available 12 hours a day, 7 days a week, and our docs, we're managing about 85% of MSK virtually. Now think about the ones we can't. People do need to see a doc.
Yep.
Couple of things. One is we now have a relationship with a company called Medmo out of New York, because we were referring some folks out for imaging. I just need an X-ray, need an MRI scan. We can now do that ourselves and keep the patient in the CJR in the upswing fold. But when we do refer out, think about this, Adam. We're now referring them out with a diagnosis. We're not saying, hey, Dr. Sylvan, go to an orthopedic surgeon. We're actually handing them off with a diagnosis. So even if they then go into physical therapy, brick and mortar or virtual PT program, it's different when they go in with a diagnosis and with, hey, go in with shoulder pain or hip pain. It's a lot more curated experience. And for the orthopedic surgeons, they're going to get a referral with something of value because that patient likely needs an operation. But here's what we do as Upswing, because we want to manage the patient not just within our 85% sphere, but the entire experience until recovery. So we now have relationships with orthopedic practices around the country where we can get a bundled, transparent price for an arthroplasty, an arthroscopy, anything you want. And all we ask in return for that referral is outcomes measurement. So we can go back to our employers or whoever we're contracting with and said, we refer Dr. Silverman to Dr. Smith for a rotator cuff repair. Here are his outcomes. So now we're suddenly not a point solution anymore, Adam. We're managing an entire spectrum of care now.
So talk about those outcomes. Talk about how they compare to run-of-the-mill ouch treatment.
Yeah, so that's a great question. We did a pilot study here with the state of Connecticut, a no-cost pilot, no cost to them, obviously a lot of cost to us, and this is what you do as an entrepreneur. You just reach back in your pocket, but right. to be wonderful, the state of Connecticut Health Plan, a great partner of ours, they gave us access to 25,000 members, and we needed data. We know our model works, but you got to prove it. Can't say that it works without data. So they gave us access to a 10% of their population, about 25,000 members, and no marketing. It was a sub rosa kind of view. Hey, you guys do it. So we had some webinars to get the word out, a couple of email campaigns. And after 15 months, we called for timeout. We had enough. So we had 5,000 people come to the platform, 500 engaged. And that was a study group. And the state of Connecticut uses as their actuary and broker, I believe, Siegel Health. Have you ever heard of Siegel Health? S-E-G-L. No. Anyway, they're a third-party company here. So they took our data, and they did an analysis. And look, we're quasi-scientists. Retrospective, claims-based, matched cohort analysis is fraught with challenges. It's nothing you and I would write up in the New England Journal or Journal of Bone and Joint Surgery. But the data was really compelling. And it was, again, not our data, but third-party data, in that it showed a 38% reduction overall utilization in services being injections and PT and imaging and surgeries with a savings of about $1,100 per member.
Wow.
We dove into that data a little bit deeper. We then surveyed those members that used us, and listen to this. 49% said that had they not had access to our platform, they were going to an ED or urgent care. And 40% said had they not had access to the platform, they were going to make a brick and mortar appointment. So all of this data is not rigorously analyzed, but it tells a story. Mm-hmm. The story is, Adam, but the model works. Now we're looking at this data prospectively through the state of Connecticut. We were selected to be their MSK vendor. We're about 6 months into it now, just starting to look at some preliminary data that'll corroborate the pilot study.
So in this last little bit of time that we have together, I'd like to start to talk about barriers to scale. And I know you're sort of a self-described optimist. You look for the bright lights, the bright spots in everybody and in every situation. But as somebody that works in a digital health company who have had interactions with lots of people in various vendor relationships with healthcare is really hard to get your foot in the door of. And if we step back for a second and talk about how do upstart companies, how do startup companies you know, get in the door, not just get in the door, but scale? How do they move forward in a business model that makes sense? What are those impediments? What have you experienced in terms of struggles or obstacles that have been particularly troubling to you as somebody who works in the field, somebody who is a senior physician who has a great idea that really you have the data that says it should scale, you have the patient experience that says that it should scale. What gets in the way, and what can be done about it?
That is a great question. I will be clear to your audience. I've done a lot of things in my life, professionally, athletically, and so forth. This is the toughest thing I've ever done. I'll be honest with you. Again, as a surgical personality, I don't have a whole lot of patience, but I've had to learn to really cultivate them here, because there are headwinds and there are tailwinds. And I looked at tailwinds as the bright spots, and I run at them and I try to make them work. But there are a lot of obstacles, Adam, in any innovation. And again, you and I are familiar with the diffusion of innovation curve, and how do you get to that 16% adoption of anything? All right, in any new innovation, be it a social or a new tool or technique or whatever, how do you get to that the early majority buy-in? It's particularly difficult in healthcare because of the headwinds are a little unique. First of all, you got what some people call muscle memory or incumbency, or people like to kind of do what they like to do. And it's hard to overcome that. And again, as an arthroplasty surgeon, my patients tend to be a little older, so you offer them a virtual option, a telehealth. They go, oh, no, I'll come sit in your office. I mean, my kids aren't going to do that. I'm sure your kids aren't going to do that. They want it
Right, exactly.
on their phone. So, I mean, that's one, is just overcoming, is getting engagement, even when it's out there. But other obstacles are that there is a lot of competition. MSK is a huge space. It's about a $700 billion a year industry. There's a lot of competition. I think that our differentiating pointers are becoming a little bit more clear to the market. So I don't even have to explain it as much anymore. But there's a lot of competition, and a lot of the competition is in the digital therapeutic realm, and they're extremely well capitalized. And they capitalized before the market turned. So that's another obstacle, is access to capital now is really, really hard. You've got to have a solid business model and a good trajectory to revenue. Otherwise, good luck with that. So that's always a challenge. And then again, just the whole field of healthcare is heavily regulated. We like to think of ourselves as independent entrepreneurs. Even in the digital space, which isn't as regulated as the brick and mortar space, it's still highly regulated. Be very, very careful getting into Medicare Advantage and ACO REACH. You got to really be very, very careful. So there are significant headwinds and obstacles, and a lot of it's just overcoming that inertia. And again, if you think about the $4.1 trillion a year that we spend, and we know $1 trillion you can put in the toilet bowl, but that's somebody's income. And they also don't go down easy. And you know how things work in our country. It's just, you got to have your lobbies, you've got to have your advocates. So there's a lot of headwinds, but there's also a lot of tailwinds, Adam, and I'm optimistic about the future.
So I'm curious, back to CJRI, as you were breaking down sort of the improvement in payment that the orthopedic surgeons and the anesthesiologists were going to get as a result of the bundled pricing that you did, you sort of off the cuff said, and the hospital is going to take a haircut. So as the physician entrepreneur, how did you keep engagement with the hospital? And how did you corral them to stay at the table to continue to negotiate when they were going to get paid? I think you said 8% less, or whatever the haircut was going to be. What was the secret in keeping it all together?
Again, I've learned to be a bit of a social scientist, behavioral therapist, because it's a great question. But the reason why we're able to do that is several-fold. The biggest one is this: new volume, Adam, is new volume. It was not converting existing contracts to bundle payment contracts, because that would have made no sense to them at all. And I would have a hard time saying, give up all of that, even though I don't agree with what they were getting reimbursed. But hey, it's business is business. So this was the promise of new volume. All right. And, it took a little leadership work with the powers that be to show them that. But we trusted each other. And it comes out, I'm going to use that word over and over again. No one trusts each other in healthcare, and it's that you've got to generate that. I mean, here we have 10 surgeons from 5 different practices. We had to overcome that. Oh, Steve, you're with that group here.
Right.
You don't, and the hospital trusted the leadership of CJRI that we had looking out for them, watching their back. We were going to bring in new contracts, and hospitals are competitive here. Hospital A wants to beat Hospital B and put a billboard that we're a so-and-so center of excellence. So it worked, and I think they ended up doing fine. And for my part, I asked for something in return to the docs. I said, look, you're going to get a bump here, but you need to follow these protocols, all right? I'm not asking for a lot. We need your cooperation. Not 100% of the time. There's always room for, Mrs. X needs something different, but just pay attention to them, contribute your data, collaborate with us, and it works. It's just, remember Dan Pink, The Intrinsic Motivators of Behavioral Change. Maybe the best TED Talk I've ever seen, ever. It's called The Puzzle of Motivation. And he talked about money being an extrinsic motivator behavior. Everybody wants to make more money, but it doesn't make you think. But CJRI, we gave our surgeons autonomy, mastery, and purpose. And that was kind of the cog that turned that flywheel for us for years.
I think that's an amazing set of observations, because as I have conversations with entrepreneurs in the digital health space, everybody always struggles with, how do I even get the attention of the health system, to be able to sell into it? And what are the data points, or what are the pieces of information that I need to be able to provide? And the things that I heard from you is, first and foremost, you've got to be willing to listen. You've got to be willing to sit down at the table with the health system and listen to what their concerns are. And then in your pitch to them, be able to address, those specific concerns. But even and above that, you were talking about providing real value in the form of new business to the hospital. And that was really the linchpin for the hospital to come in, even though they were going to get a little bit of a haircut on each of those particular cases. Does that sum it up pretty well?
It does. It just fostered alignment. And our anesthesia, anesthesia for years was sort of the unsung hero of the value movement, at least in orthopedics. But with their magical blocks and pain management protocols, they deserve a great deal. We got better and faster and more efficient, but it was an amazing teamwork approach, because we would come up with some cockamamie protocols and they would say, it's going to cause bleeding, it's going to cause this problem or that problem. So we have in fact, as you probably know, our lead anesthesiologists are actual full shareholders in our management company. So they're not ad hoc or visitors, they're full shareholders.
So there was a lot of foresight you had in putting this thing together called the Connecticut Joint Replacement Institute. It was more than just clinical protocols. It was a way to bring disparate parties together to the table to, again, as you say, put the patient and their family at the top of the top of the decision tree.
That's right. Yeah, there's a lot of tailwind out there, Adam, and it is a bit depressing when you read that the payers in the first 2 quarters of 2023 had something like $700 billion of revenue and $40 billion in profit, and they're not happy with that. It's not enough. But I do think there are some seismic events, at least in the world that Upswing is in, which is mostly self-funded employer space right now, that is going to upend a lot of this, and that's the Consolidated Appropriation Act, and that's really bringing the employer from the back seat to the front seat, because they are now the fiduciary. They can no longer say, I'm going to use MSK option X if MSKY gives better value. They just can't do that anymore. So
Right.
I think we're on the verge of some really major great things that are going to advance. I know people are tired for 15 years of value-based healthcare, but we're going to see the scaling of advanced primary care models where they are the center of the universe, as they have to be. You're going to see consolidation of large employer purchasing groups like you've never seen before. And you're going to see the condensation of solutions like Upswing with other partners. I mean, yes, we manage maybe 20% of spend, but we're already looking to partner with, cardiometabolic companies, diabetes companies, behavioral health. 40% of our patients have behavioral health problems. So although we're very proud of looking at this MSK continuum, we're already, Jay and I, thinking well beyond that, moving into other chronic conditions to collaborate and then offer the employer one-stop shop or the advanced primary care company one-stop shopping. That's where it's going, man. I think
that's unbelievable. As my producer Chris said when I told him about you, he's like, how does he have time for all of this? He's a full-time orthopedic surgeon. He's running this great joint replacement institute. And he does all this other stuff. Where does it all come from? And I think that's a testament to you, Steve, and to the work that you've done.
It's been fun.
I think you've been, not just a leader in orthopedic surgery in your field of choice, your profession of choice, but I think you've also become really an inspiration to a lot of people who in the past had not necessarily viewed themselves as entrepreneurs or innovators, and you've given a lot of people the opportunity to rethink their careers and rethink the way that they perform within healthcare, not just docs, but I think administrators as well. You've pushed to improve and to change their thinking, and I think that that's a real testament to your commitment, and we certainly are appreciative of that.
Yeah, Adam, as you well know, it's always a team. CJRI was blessed to have executive director and program director that bled CJRI, and our staff there would do anything for us. Anything. And I'm talking about everything from the environmental cleaners all the way up, because we had their back. And it just an amazing, amazing experience. But it is an amazing family. And I would tell your audience, young entrepreneurs, we need physician leadership. We absolutely need physician leadership to step forward, both in administrative roles and in these various innovative positions. As long as you've got a mission, right? A mission to improve the common good. I think it's a great opportunity in the future. Go for it, man.
Well, Steve Schutzer, Dr. Steve Schutzer, orthopedic surgeon, co-founder of the Connecticut Joint Replacement Institute, and most recently of Upswing Health. Thank you so much for being on the podcast. We really appreciate it.
Thank you. I very much enjoyed the conversation. Be well.